Quality Patient Safety Committee today on behalf of my colleague, Director Ken, who's the chair of this committee. So I'll be acting chair today, and I want to welcome everybody back. Good to be back in person. And so I will ask Madam Secretary for the roll call, please.
Director Pratt is absent, and serving as a substitute member, Director Story.
Present.
Director Sorrell. Director Webster Cross is absent. Chair Kim is absent, and Acting Chair Garza.
Present. Thank you.
Actually, for the record, Director Robinson was here. I do not see him, so yes, you have a quorum. Sorry.
Thank you, Madam Secretary, and I will formally call the meeting to order. I guess I did that. And the next regular meeting of the Quality Patient and Safety Committee is scheduled for Thursday, June 22nd at 10:30 a.m. And Dr. Claudia Fegan, our Chief Medical Officer, Dr. Ruby Kumapoli. Oh, got it. Okay, thank you. Okay, so I'll ask if there is anybody registered to provide in-person or virtual oral testimony or submitted written testimony to be included into the record.
We did not receive any registrations, nor did we receive any written testimony.
Okay, thank you, Madam Secretary. So we'll move to the report on the quality and patient safety matters. No action will be needed for these items. This is only informational, and we will move to the HRO dashboard reviewed by Dr. Mikaitis, sorry about that. I will work on that. Chief Quality Officer.
Okay, thank you. Good morning, directors. We will start with our patient experience metrics. This is, again, our roll-up likelihood to recommend. We did see a slight decrease from 77 to 74. March into April, and if we go to the next two slides, we'll see some of the contributing metrics. So let's go back. So this is our nursing communication. Had a bit of a dip, is still pulling up the average. However, we went from 77, we had a really nice increase February to March from 64 to 77. Saw a bit of a downturn 77 to 70 from March to April. Our rolling 12-month, however, has been increasing. We're up to 70% now for our nursing communication. Next slide. And we have our, other way. That's okay. There we go. So our environment domain. And this too had a bit of a downturn, 62 to 56% top box, and that was March to April as well. So we have several interventions in play for both of those roll-up metrics, including using a Press-Ganey tool for leadership rounding to engage with our staff, and some visual management for our domain measures as well. Next slide. Shifting to clinical documentation, we have some work going on right now. This is a bit of a watch metric given that it's behind about 3 months, so we hope to see starting in May a bit of an uptick, but we are at 2.93 for surgical and 1.25 medical, both essentially flat. Again, we for surgical engaged with many of our subspecialists, the department and division leaders, and have some action items in play with collaboration with our ATOS CDI partners to provide direct feedback on a weekly basis. We're going to be starting that work with trauma in about a week or two. Next slide. This is our observation rate. We saw a nice downturn and improvements March into April from 31% to 28%. Again, improving our documentation should help us make a better argument to shift our patients into inpatient status. Yes, Director, sorry.
Excuse me, would you mind just a little slower?
Oh, of course. Yeah, okay. Thank you. Next slide, please. So this is our observed over expected mortality, and as we improve our documentation, again, the expected mortality rate should improve. We did see a nice downturn, so we want to be less than 1, which means we have less mortality than expected, and we moved from 1.38 down to 1.08 January into February. Next slide. This is one I'm very excited about. We've had a very nice increasing trend in our Step 1 bundle performance. So this is our sepsis measure for CMS. Looking back to around September, our rolling 12 month was at 19%. We've currently increased up to 35%. Kind of a three-pronged approach there between documentation, educating our clinicians, and then also working on process improvements. For those who were on the committee towards the end of 22, early 23 in December, we did a rapid improvement event in the emergency department that focused in on very process-driven changes. Leveraging the data, we saw that a lot of our second lactate fallouts were leading to our misses for this measure. And we're putting in place a lot of steps now to really put kind of processes to make sure that those misses aren't continuing. So building out essentially a reflex order for our second lactate. So we have to address some of our more common fallouts. Next slide. So this is a raw count. I do have updated numbers from earlier this week. We are at 8 now through April, which puts us on track, assuming a linear progression, that we would be at about 24 for the year. So a very nice trend in terms of improvement year over year. Next slide. Our readmissions work, we had a very nice decrease, 11 down to 8%. Again, driven by Dr. Jabbar and the readmissions team. They're focusing on better access on transitions of care after discharge. Next slide. This again, so this is EDAC, excess days of acute care. So after discharge, we have, the readmissions are when they come back as inpatients. This is a bit of a higher bar. This is when patients come back for any type of acute care utilization, so ED visits, observation, as well as inpatients. So we did see a bit of an increase that was driven primarily by a urology case. This patient had to come back. He came back once in observation and then was also readmitted in the subsequent 30 days after his index discharge. So bringing additional support to that patient. Next slide. Our throughputs, again, very nice drop late 22. This was driven by process change in the emergency department, putting our providers more out front so that there's less of a wait between triage to being seen by a provider, and that trend continues. Next slide. Our ED median length of stay, we actually just had a call with our ED team, the subgroup for this, and they are right at goal at 224, 225 for length of stay to discharge. They're really focusing in kind of multifactorial. There's probably 10 or 12 different smaller things that all add up to throughput opportunities, so they're really trying to knock them down kind of one at a time. Next slide. This is our variance to geometric mean length of stay. So again, this is a bit driven by our throughput and also driven by how we document. Essentially, we are about 2 days above where we would be predicted to be for our length of stay based on the severity of illness of our patients.
Let me assess, if you will, a question back on slide 13 about throughput through the ED.
Yes.
Is that discharge from the institution, or is it inclusive of patients who are admitted to the inpatient unit?
So no, these are patients who discharge from the ED, so they go home. They're
From
not
the
being
institution.
Yeah.
What is there a slide here that, in terms of EDs, I need to wait?
ED.
From the ED to the inpatient?
Oh, in terms of how long we're waiting, there's
Yeah.
not. No, we don't have that. That's in the DAC. I could certainly get that for you, but yeah, we don't have it included in the data.
Okay. Thank you.
Thank you. Okay, Debbie, next slide. So shifting to our ambulatory measures, we have mammograms, which are relatively steady. We're in the mid-50s for completing mammogram screening. Next slide. And blood pressure control, also fairly steady. Again, our subgroups have just been meeting, and we are going to be hearing from our HEDIS team today for a bit of a deeper dive on the work that they're doing, but a lot of that is really just kind of getting started right now. Next slide. And these are our A3s, so that'll be tactic driven. If there's questions, we can refer to them, but that would be the end of the report. Any questions?
Any questions or comments?
For the HEDIS, thank you. For the HEDIS work group reports that you have, what are the activities that you're employing to increase the percentages for screening and blood pressure?
So yeah, very process driven. We actually have the tactics up there.
Okay.
Yeah, so, let me refer to it. I can't really read it there, but, and again, we will be hearing from the HEDIS group, as an update. So a lot of education, a lot of, gap analysis, and then reaching out to patients as we realize that they're due. And then some process-driven work around blood pressure control, in real time. So that measure can be a little bit tricky. It's really the, in general, it's the last measured blood pressure. So a lot of times as you're rooming a patient, they'll sit them down, they check the blood pressure. They haven't had that time to really sit, relax, let the blood pressure come down. That ends up elevated. So, you know, how do we build in processes to kind of recheck at the end of the visit, those types of interventions.
Thank you.
Thank you.
Okay, thank you, Dr. Makitas, appreciate that. Let's go to.
Excuse me.
Yes, sir.
Did I miss the slide on length of stay?
We have the geometric mean. It was the one right after the ED. Debbie, if you want to back up. I think it might have been 14. There it is. So that's our variance director story to our geometric mean length of stay. So it's essentially a risk-adjusted variance to where we're supposed to be targeting, right?
Debbie, what page is it? Here.
14.
14.
14.
Okay. Page 14. Thank you. I'll pull this out and look at it.
Dr. Harrington?
All right, Director Harrington.
Yeah, I have a question. It's on slides 15 and 16, breast cancer screening for women and hypertension, blood pressure. How do we determine what the goal is going to be? Is that something we're trying to achieve because it's a national goal, or is what we think is realistic? Or,
Yeah,
you don't have to stretch goal.
Yeah, so we actually started with, you know, initially the rubric was what's going to get us on publicly reported to 4 stars and an A on leapfrog. And we did on several measures kind of take a step back and say, okay, well, let's not really over push and let's make it more realistic and kind of do incremental increases. So
you don't have a stretch goal in mind.
Is there a national recommendation?
You know, I'm not sure.
Okay, any other questions?
I think we're gonna go.
Thank you,
into
Doctor.
I think everyone's.
Okay, we'll move on to item 3B, regulatory and accreditation updates reviewed by Cynthia Fish, our Director of Quality Regulatory Affairs and Accreditation, and Irene Marks, Director of Quality Improvement.
Okay, good morning.
Good morning.
Thank you for having me here. I'm going to present the first slide. So we're going to be discussing the regulatory updates. So in regards to Provident, we are still waiting for our GAP survey, our CAP survey, which is a laboratory survey. They are still due here in 2023. We are also in the window at Provident for Joint Commission's triennial. And so in the meantime, we are doing random audits, tracers throughout the hospital. We are still reviewing weekly the findings from the mock survey and discussing the corrective actions. And then we will begin to transition to look at the audits and the data that's resulting from those corrective actions. In addition, we have started a gap analysis with the chapter owners to, again, assess their readiness for regulatory compliance. So that is also being done on a weekly basis. And at Stroger, we are planning to have a mock survey here. More than likely, it'll be in the summer, but we're still shooting for late spring, early summer. And I am beginning to meet with the chapter owners to assess where they stand for regulatory readiness in regards to their triennial survey that'll be coming next year.
What's your guesstimation on for Provident on the Joint Commission survey? What are you hearing and what you're feeling?
Right. So, you know, I have been in touch with our reps on different reasons and talking with them. I really have a feeling it's going to be in the fall. Of course, they could come at any time, so we do need to be ready, but I believe it may be September, so in the early fall.
I always worried about that issue because they're right down the block. You know, you could
Yeah.
just stumble and say, oh, I don't feel like going to New York. Let's just go with the Providence.
So our goal is always to tell our team to be constantly ready. So we're always doing everything we can, doing tracers, observations. I have that same fear. Good couple percent.
So you all are comfortable, Dr. Turner, that if they decide not to go to New York next week and they decide to stop in Providence, you all are comfortable with their presence on your campus? Thank you. That's good news. Good.
We have a good group. Thank you. And Irene, for the next slide.
So, I'm Irene Martin. I'll be presenting a regulatory update for CERMAC. And, thank you for this opportunity. We really are excited to, present, what we have been able to accomplish. It's been over a decade and a half since CERMAC's accreditation was withdrawn. And during that time period, they went through a lot of rigorous activity with the Department of Justice, with on-site surveys every 6 months for 10 years. And they've been able to endure all of that to get to the point where we are now. So we started formally preparing for reaccreditation or restoring our accreditation back in March of 2021. And we established a quality and patient safety framework and put in all the processes needed to support the compliance with all the regulatory requirements. And since then, we were also able to maintain our certification with our substance use and prevention program with the state, as well as maintain accreditation with our opioid treatment program. And during those two surveys, we didn't have any findings. And our opioid treatment program was recommended for Program of the Year. We haven't heard back for it, but we are really excited and, hopeful that we will achieve that accomplishment. And then we submitted application for accreditation for CERMAC's jail accreditation, which is the full one, back in January of last year. And we went through a mock survey, and then finally we had the official survey in March of this year. And I am pleased to report that we have now been awarded accreditation by the National Commission on Correctional Health Care, and we are really, really, really grateful. The team did a lot.
Wow, congratulations.
Thank you.
Excuse me, let me just say that's a tremendous accomplishment. I mean, you look at the timeline, is from 2008 when it was withdrawn, and that gap, not looking in the rearview mirror, but just focusing on the success that you all have had and the great work from March of 2021 in the midst of the pandemic. We had just started with the needles and arms, et cetera, and in the midst of all of that, trying to manage patient population and stand up a vaccination program, and you all to achieve this over the last 2 years is a tremendous, tremendous accomplishment. Great work. And all of the team, I'm sure. Please let everybody know that the board acknowledges that great effort.
Thank you. We really appreciate that. And that was what I was going to say. The team just worked really, really hard. The staff, the leadership team, phenomenal with just showcasing all the great work that's going on over there and all the robust processes, because the volume is really great, and they've been doing a wonderful job for a long time, but especially now. And also our nursing team, they really did this in the midst of really facing a lot of leadership challenges with over half agency managerial staff, and I just want to announce that as well. So, thank you, board.
Excellent. Thank you so much, Irene and Cynthia. Any questions or comments? Thank you, Director Story, for your comments as well. Okay, we will now move to item 3C, update from HRO HEDIS Work Group, reviewed by Dr. Charles E.D. Oweti and Dr. Vaklavik.
Okay, good morning.
Good morning.
Thank you for giving me the opportunity. I and faculties to speak on our HADIS data, which is Health Effectiveness Data Information Set, NCQA quality-based data that we're using in the county. NCQA stands for National Committee for Quality Assurance. Our main goal is to focus on two measures. As you guys can see from above, we've been working with 5 measures, but we believe that we can achieve target by focusing on 2 measures. First measure you're looking at above is controlling hypertension in individuals between the age of 18 to 85 years of age. Happy, within the last 2 years, we've worked tirelessly using what we call our MAP data. MAP refers to measuring accurately, partnering with our patients, work with AMA to ensure that we move this measure upward. So we went from about 40% within the last 2 years to about 55, and that's what you can see on board. We still have somewhere to go. Across the board, you can see most of the clinic sites in the last 3 months are actually getting close to the target. What else have we done so far? We've had a role-based workflow that we rolled out. We worked on last year, but we'll be rolling out at the beginning of this year, specifically for hypertension. The target is 63%. We are close. We are 55. We moved up by about 10%, I believe. By next year, we should be close to that target. So that's what we're focusing a lot of attention on this. Any question on this? No question. We'll go to breast cancer. For breast cancer, the same thing as well. We've worked tirelessly on it over the last 2 years. Apart from a slight dip in the middle of 2021, we have actually moved quarter by quarter, gradually close to the target of 59% as well. Some sites have had challenges, specifically because of the denominator and loss of patients. So that's where we've had challenges with those sites. So we are now able to better determine what our denominators are. So by the report that we had in April, but those 2 sites you're looking at have made dramatic improvement. So you cannot see that on the board right now. What did we do over the last 2 years? We put a lot of manpower hours on ensuring that we're reaching out to our patients. We are providing them multiple sites where they can get their breast cancer screening. We have Providence, Prenatal, and Stroger, ensuring that patients are being reached out to by targeted teams that we have at each of the clinic sites. And that is why the measure has moved forward. Do we still have a long way to go? Yes. And we believe that by focusing on hypertension and breast cancer, with the role-based workflow that we're going to roll out, which my colleague will talk about briefly, we should be able to hit those targets within the next 6 months to 1 year. Thank you. Can you just expound on Core, Inglewood, and Sunset? Yes. So the reason why they are a little bit low was the Inglewood and Senstack traditionally have an older population of patients, and we lost a lot of patients from Inglewood and Senstack. So our denominator changed, but we were still referencing the old denominator. But we realized that those denominators have changed, and actually the value in April is both sides hit target. You don't have that on the board because we already submitted it before. We worked tirelessly, several man-hours, reaching out to virtually our patients. That number, in fact, for Inglewood in April is, I think, is 58%, and that for Senstack is actually also 58%. Core is still a little bit low, and we're working on Core. Our role-based workflow will address those issues. And the biggest thing is outreach to our patients and follow through.
And I know there was a question on the breast screening rates, and so we are looking at them. The goal nationally for the last 2 years, according to the CDC, is about 69%. But with COVID, that has dropped down to about the 30s. So we are very proud of our team and what they have done. And of course, we always want to set our goals within something that we can reach and with the eye on the target for the national target and what we need to close. So they have done an exceptional job in identifying the need to have this more modern equipment, which we have brought in a few additional staff that we're currently recruiting, and we hope to expand the rate further. So it's always our stretch and what we can stretch with our eye on the prize on beating the national standard. And so commend the team getting there. They are exceeding based on where we were, but we don't want COVID to be our target. We really do want to be about that 69, which is the 2-year rate that the CDC had prior to COVID, and then hopefully surpass it so we can do better.
Thank you.
Thank you.
So good morning, my name is Beth Backlevic.
Good morning.
I'm going to just briefly go over our A3. So with our two A3s, one for breast cancer and one for hypertension, what we did is we brought the team together and we talked about with our lead clinic providers as well as our managers, where are we today and where do we need to be and how are we going to get there? And we talked about process flows. And so we've put together as a group process flows, engaging every member of staff in the clinics, remembering that we're putting the patient at the center of all that we're doing. And so we looked at where we were previously and identified there were a couple of roles that didn't have access to some of the reporting mechanisms and data. And we created these workflows to include them at the beginning. So some of the things that we did, as Dr. EDL and Mr. Rocha had identified at SENSTAC, Dr. Lynn is our lead for that breast cancer initiative, and she's at SENSTAC. One of the things she talked about was having same-day mammograms for women who are coming in. So when women are coming in, we're engaging all of the staff, including the MAs, to look at when their last mammogram was, and if they were interested in getting it same day, and would they get to the site to get that mammogram. So this team has been putting together the workflows of which staff can do which role to make sure that we have every patient covered when they come in for their visit. These workflows are now being communicated and all of the staff are being instructed on the role that they play to improving our patient outcomes. And so that's in our A3, and that's one of our primary goals is to get everybody informed and educated and playing an active role to do that. And our goal is to have that completed by July of this year. Any questions on that?
Great work on increasing these numbers. With the recent recommendation that we consider breast cancer screening starting at age 40 now, particularly with minoritized women, are you looking at either a review preemptively to then make sure that you recoup those members who may not have started screening until 50?
In fact, actually, I agree. This is for reporting agencies. Most of our providers are advised to start their screening at the age of 40 as well. That is what we generally agree upon. In fact, most of our patients less than 50, their data, we have data on that, and they actually do much better.
That'd be good. Okay. That'd be excellent. And then secondly, as you're now nearing these goals that you're having your target, are you preemptively looking at the next goal with the CDC now recommending colon cancer screening, particularly for, once again, minoritized men, in being able to now look what might be your next targeting goal for this type of program?
So with regards to that and colon cancer screening, we're actually looking at those. Okay. These were our two that we were focusing on, but there are teams looking at all of those different metrics, and so we'll continue to do so.
Great. It'd be great to see those numbers as they're developing as well, too, particularly with the recent deaths of those that are so young, certainly in their 40s. Thank you.
Thank you.
Thank you.
Any other questions or comments? All right, thank you.
Great, thank you.
Thank you.
Okay, we will move to item 4A. There are no appointments or reappointments as Stroger Hospital Department Division chairs, so we'll move to item 4B. EMS MEC reports being given by Dr. Kantoran. He will present the Stroger Hospital Quality Committee summary for informational purposes and will present the medical staff action items for the committee's consideration.
Thank you. Good morning.
Good morning.
Good morning.
Good morning.
So the report of our credentials committee, as accepted by the EMS, that we're now presenting for your consideration is before you. There is not much by way of significant reports or adverse reports to talk about them. So if there are any questions, I will be glad to take them. And then now we can go to the summary of the HCQPS committee report for the month of March. This is based on the meeting of the HCPS committee. There are a few items that are not on the screen there, but I would mention them quickly. The HRO, on the HRO, the 30-day readmission rates continue to improve. The number in March was 9.73%. Of that, considering all plans and all courses, and which actually met stretch goals. The case mix index for medical was flat at 1.24. There was slight improvement for surgical, which was at 3.23. Now for the HEDIS report, the metrics have changed for the HEDIS. You saw in Dr. Mikaitis' report, but at that time we were still tracking the hemoglobin HA1C of greater than 9% for in-care patients, and that was down to 22.5%, which was less than a goal of 24%. So that's probably why that fell off the new metrics. For patient safety update, there was a small increase in serious safety event reporting, but I think that it was due to increased reporting generally, which was actually a good thing for the organization. Majority of the patient safety event reporting was from our nursing staff, 60 to 70% of that, and the rest were from our trainees. There was the culture of safety survey results, which actually show that our frontline staff are feeling more comfortable reporting safety events. Again, that's a good thing. Coming now to some of the things on the screen here. For strokes, we had 252 patients for the year. The stroke team met their goals in almost all of their reporting metrics for the year, which was great. Now there was contract management presentation as of March 2023. Currently, we have 632 active contracts, and business review monitoring. They are reorganizing their procedures within the department. I think they are going to electronic, which will result in better tracking of those contracts and their performance. Now, for the ACHN non-HEDIS presentation, the team, they are developing some key drivers to kind of track, what our patients really want, and our patients look for things that work together for their care improvement. Things like providers are explaining their problems, and then the ease with which they obtain referrals. So the team, they are creating goals based on the Press-Gaining guidance and those are based on the eye care and the compassionate journey recommendations. And then the patient experience, we have that up there, that our staff, they are getting training to improve patient experience, and that's in the first part of the screen that's up there. So, are there any questions?
Related to your stroke numbers, it appears that less than 5% of the patients seen for strokes received any type of interventional activity, TPA or radiology. When are you looking at your criteria to potentially increase the potential earlier intervention for stroke to minimize potential negative outcomes and sequelae?
Yes, Dr. Sarah. Our stroke team, they've been doing a lot of great work, and you see those reports in subsequent meetings.
Thank you. And is there a comparative analysis with other large hospitals to see if there's a population-based issue that may be accounting for the larger percentage of strokes that we have in this area?
I can I can help better into it. So we are looking at expanding. So we're right now just primary stroke, and that's why we get a lot through because of the safety protocol that the ambulance have, which is good. They take them to thrombectomy capable and comprehensive strokes first, which we're right by Rush and by UIC that have that. We are on our journey to become thrombectomy capable. So a lot of the strokes that we get are walk-ins, and we do have capability to do it. We want to be certified to do it. And so we're right now getting a lot of walk-ins, which usually means they're primary strokes that we can treat medically. And so we are escalating to be able to have thrombectomy capable and then onto journey of comprehensive. And once we do, we'll be able to get more of that ambulance traffic and change our demographics a little bit. But we're very proud to have been able to have been the primary stroke on our way to be thrombectomy capable and getting all the backup services and requirements underway, and then hopefully moving into full comprehensive. We did structure our neurosciences line that is underway as well. So our neurology department is working with our neurosurgery department to create an enhanced neurosciences line that would also be able to offer more services for any cerebrovascular disorders. And so we're excited. We're on our journey and 100% agree on the metrics and what we're doing to do our community analysis, because I always say we need to treat what's in our community, and there's a lot of stroke because of hypertension and undiagnosed hypertension. So we're also working on the front end to hopefully start a pretty exciting program in the next few months. We'll be briefing about on how we're going to try to get individuals to get diagnosed and be able to get on the proper medication faster to do further work on the blood pressure work. And so excited, things coming, we're on the way.
Looking forward to hearing that. That's very important. Thanks.
Thank you.
Thank you.
Thank you. Thank you, Dr. Arcangelo. Next, we'll hear from Dr. Mark Wolfman, who will present on the medical staff action items on behalf of Dr. Marlon Kirby, President of MEC, for this committee's consideration.
Thank you, directors. I'm remote. I hope you can hear me okay.
Yes.
Great. Yeah. So I'm reporting out the med staff appointments, reappointments, lots of activity going on. And that report is with you in your packet to show all the different providers that are being credentialed and reappointed and moving through the process. So a quick summary of the quality improvement activities. So we've been working collaboratively on updating the summary presentation for the impending Joint Commission. We have a really nice presentation put together. We thank the quality department and all of our managers for their role in helping us prepare that document. A few highlights, just patient access team is working on increasing portal use for our patients. So we're kind of stuck in a very low number, 10 or 12% of patients with portal access. So that's an important issue because electronic communication is so useful for a lot of the reasons you've been discussing this morning, being able to reach out, connect with people, get them in for indicated tests through electronic communication. Inpatient care coordination continues to go really well at Provident. Lots of interdisciplinary rounding and teamwork to help with getting the right patients in the right beds and then getting them discharged in a timely manner. Behavioral health initiatives, we're working collaboratively to get our behavioral health patients. Chronic disease management is a big deal. As you know, those with serious persistent mental illness who are on medication management suffer chronic disease life-shortening events at a higher rate. So our behavioral health team have been great about getting their patients screened for diabetes, hypertension, cholesterol disorders, and then getting them tucked into behavioral health primary care, which we do in an integrated manner with behavioral health. So those are a few highlights. The ER is working on turnaround time and their cycle time, coordinating with radiology and with transportation. Imaging is one of the things that can hold up cycle time through the ER, so they're trying to expedite that and having some good progress on that. And last point I would call out is just the OR. The cases are going up, so there's a few work groups working collaboratively on time start and turnover, getting the rooms turned over to process through. So there's work to be done there, but it's all the right things have been identified, and I think it'll help with throughput there and getting volumes up in the OR as well. So that's the end of my report.
Thank you. Any questions or comments, please? Thank you.
Let me just ask a question about the cycle time you referenced in terms of the ED.
Yes.
Because one of the areas that across the country, patients and their families complain about is obviously wait time in our ED, and I know that's coming down based on the report we've already heard. Is there, would technology enhance our throughput in the ED in terms of changes and upgrades in technologies that's available today in the organization?
Great question, and we do look for ways to do that. One of them it would be the medication refill process. One of the reasons patients come to the ERs, they've learned is a workaround to go to the clinic for medication refills, and they'll get a 30-day or supply of meds. But that throws off our refill process. It doesn't give them the 90-day supply we like. So that's an opportunity. We're looking at refill management to have that be electronically. Patients should be able to reach out electronically and easily get access to us before they run out of their medications. So that will take some of those walk-in patients out. And the other, I think, thing we're looking at is a fair amount of the patients who leave without being seen are low acuity. The ER staff calls every one of those patients that left without being seen to find out what happened. Most of the time, they were not seriously ill and weren't willing to wait a few hours for a minor problem. So those are also things that we should be able to do with a fast track that we don't currently run regularly, but sort of a quick urgent care, and also being able to have those patients get access to same appointments in their clinic, which is a much more appropriate place for those minor and chronic complaints that they have. So I think you're right on target with that, and some of the things we're doing with portal access are directed exactly to your point, to have patients be able to reach out to us electronically, and we communicate timely with them in a way that could help them coordinate their care without an ER visit.
Is there educational program with respect to the patient portal and the utilization of that technology that we use today?
So we do have an educational program both through the primary care teams whenever someone has it about how they can get onto patient navigation. We are also wanting to expand it so that we have some scope of services for individuals who may not be patients. Because a lot of the scripts that we get are patients that ran out and they're scared that they're not going to have something in the morning. So they come into the emergency department to be able to get it, even if they're with other practices. The doctor will see them and help stabilize them. So what we're trying to do is to educate about our portal, which we do, and our primary care team does a good job explaining through the Cerner portal and how they can get on and how they can get their medications and get access. But soon, we briefed the board before about our One Source project endeavor, and that will be an open access. So we hope to start connecting patients soon with some additional services online that anybody would just be able to download our app and be able to start getting some services soon. They will grow, but the first services we're looking at are appointments, possibly refills, and scheduling, and helping to have even more services online. So we do believe wholeheartedly and have been investing. The technology can be a great way that we can see more people in the future and make medication and the practice of medicine much more available to individuals who sometimes have hectic schedules, difficult lives, to be able to get here on time. And so we are working to create a suite of services that are in production right now. But we do educate right now on the app, on our current connectivity that we have to our patient portal. We are going to be expanding that, so even if you haven't seen us, because right now to access the most of services, you have to be an active patient to go in and log on. The app will make it available to everyone, even if you're not an active patient, on how you can get some basic services. And so the two are being developed and will be coming forth soon. They're in development because we do believe that moving the front door to healthcare is important and making it available, and the technology has a place in that. So we'll start with scheduling some basic services. We do have nurse hotlines as well that we're advertising, and are going to start advertising more, where individuals could come. So maybe they wouldn't have to come to the ED, they could call a hotline and get some assistance. So we'll be expanding those services, and we'll be doing some outreach campaigns to educate our patients over the next 12 months.
I know you referenced this before to the board of directors, but that's something that I would appreciate hearing on a regular schedule basis, about where you are on that timeline with respect to that patient portal, because AI is going to be critical, as we all know, not only in our lives, personal lives, but in the healthcare delivery model as it changes. So those updates would be appreciated on a more frequent basis.
Thank you, Dr. Director.
Come back.
Okay, thank you. We'll hold, the action items for a combined motion in a few minutes. Item 4C are the, April 2023 minutes. These were approved by the board at the April meeting, but are being presented for the committee's review and discussion if necessary. I'll ask if there are any corrections that need to be made to the minutes, please. Okay, hearing none, we'll hold that combined motion. At this point, I would like to ask for a motion to allow Director Bott to participate in this meeting remotely as a voting member. Is there a motion, please?
So moved.
Thank you, Director Story. Is there a second?
Second.
Thank you. All those in favor? Aye. Any opposed? No? Okay, so that motion carries. I'd like to entertain the following combined motion to approve the following. Approve item 4B, Stroger Hospital medical staff appointments, reappointments, and changes. Approve item 4B, Provident Hospital medical staff appointments, reappointments, and changes. And accept item 4C, April 20th meeting minutes. Can I please have a motion?
So moved.
Thank you, Director Scar. Is there a second?
Second.
Thank you. All those in favor? Aye.
Aye.
Any opposed? Okay, so the ayes have it. Let's see, so the next item, I believe, is, we'll now be going into closed session. Action is not anticipated to be taken in open session after the closed session meeting has adjourned. So we will proceed for a motion to go into closed session. Is there a motion, please?
So moved.
Second.
All those in favor?
Aye.
Chair,
Yep.
would you need a roll call vote to go to closed session?
Oh,
And if you
pardon
can,
me.
if you can cite the exceptions to the Open Meetings Act, just the numbers, it's 1, 11,
I got it.
17. Yeah.
Yep, okay, let's see. Okay, we've entertained a motion to go into closed meeting pursuant to the following exceptions to the Open Meetings Act. 5 ILCS 120 or backslash 2 C1, 2, 12, and 17. Okay, so now I ask you for a roll vote. Roll
Thank
call
you.
vote.
Roll call vote on the motion to go into closed session. Aye or nay? Director Bott?
Aye.
Chair Garza?
Aye.
Director Sorrell?
Aye.
Director Webster Cross is absent. Chair Kim is absent. And I apologize. Director Story. I was looking for my substitute member, I'm sorry. And Director Story.
Thank you. Aye.
Thank you. You have 4 yeas and 2 absent.
Okay, thank you. We will now go into closed meeting. Okay. Yep.